Hello everybody and welcome to this episode of our podcast Getting to Better Together, sponsored by the Centre for International Development, Social Entrepreneurship and Leadership of the University of the Sunshine Coast. And before proceeding any further, I wish to acknowledge the traditional custodians of this land, the Gummi Gubbi people, and pay my respect to their elders past, present and emerging. As we've been emphasising throughout this series, our modern way of life has led us to pay little respect to this notion of custodianship. In this industrial age, we approach nature as if it was something over there from which we can exploit the resources which it provides with little regard to its innate features and its integrity, its wholeness. With little appreciation of our own critical interconnected with us, which is in stark contrast, of course, to that held by so many within so many different indigenous cultures, including Aboriginal cultures, of course. But as the current COVID pandemic is powerfully illustrating, nature has a habit of hitting back against these abuses, sometimes with unharnessed ferocity. As the Roman poet Horace had it, if you throw nature out with a pitchfork, it will come back with a vengeance. Nearly 220 million cases worldwide, with more than 4.5 million deaths, is some ferocity, and its momentum continues, vaccinations and social controls notwithstanding. The virus responsible for the current pandemic is one of many, which through the ever-increasing human encroachment into the wilds of nature have jumped from wildlife to humans with sometimes very critical impacts, not just on our health as individuals and communities, but as our entire way of operating as societies and cultures. And there's no doubt that under these circumstances, we need a deep and urgent focus on getting to better, and there's no better way than we can do that by doing it together, wearing masks, respecting social distancing, accepting governmental travel restrictions and lockdown mandates, getting vaccinated and so on, are all potent examples of the need for cooperation and collaboration. But at the base of all of this, I would argue, is the need to embrace what science is telling us about the COVID virus as a transmissible and virulent infectious disease agent. And what we should do in getting to better together is to understand these basics. These matters are of particular interest to my guest today, and I'm delighted that he's accepted our invitation to share his vital insights with us. Matthew Mason is an educator and researcher into infectious diseases and their control, and particularly within the context of culture and society. Morning, Matthew, and welcome.
Good morning. Thank you for having me.
Matthew, could you take us right back to basics with some explanations of what is meant by terms like transmissibility, virulence, and indeed what constitutes a pandemic?
Okay, so I guess the first place to start is, I think, what is a pandemic? And infectious diseases are with us all the time, from a runny nose that we used to have and not think much of, through to what we're seeing now with this global spread of a respiratory disease. So when we talk about diseases, we can talk about outbreaks in a number of different ways. So you might have children in a childcare centre and they have a gastroenteritis outbreak. Happens every year, happens frequently. Any parent will tell you that, and as will early childhood educators. We call those an outbreak. Usually they're very limited and self-limiting, don't cause a whole heap of harm potentially, but are disruptive to that organisation at the time. If we go a bit bigger, we can talk about an epidemic. That we could have an epidemic of rotavirus, for instance, if we've got a spread of it across, say, Queensland, for instance, or Australia. It's larger. It's still a little bit contained, but it does cause illness to a lot of people. It causes disruption to services and to lives. A pandemic occurs, and there are various different definitions, and the World Health Organization now tried to retire the phrase pandemic during the Ebola outbreak in around 2014, because they tried to move away from calling it a pandemic to what we have a public health emergency of international concern. And there were reasons for that, because the term pandemic is loaded. And what we saw with the Ebola situation was there was a reluctance to say this is potentially a pandemic, or it is a pandemic, because of the economic and financial implications of doing that. As soon as we say there's a pandemic, things happen. And whilst the World Health Organization in Ebola and also at the early stages of COVID said, okay, you don't need to be shutting borders and you don't need to be doing these sort of things at this time, but as soon as the word pandemic was mentioned, governments went, right, that's it. We're shutting the curtains. And trade stops, travel stops, and there's that big financial and economic input, as well as the societal damage that those do. That doesn't particularly make a mention. They do now because we know what happens because we're in it. And so, but essentially, a pandemic or a public health emergency of international concern is where you have a disease that is significantly going to impact a community, and it's spreading across international borders, and it's got the potential to go a long way. We've had a few, the influenza during the early 1910s and those sort of areas after the Second World War. We had H1N1 and swine flu sort of maybe getting going. We've had SARS, the first SARS. We've had MERS, looked like it was going to do that, and it's still around. It just hasn't blown up like COVID-19 did. Had Ebola that nearly got there. It did go across some borders, but didn't make that. Got into America, but it didn't take off in the fashion that a pandemic would. So, for a true pandemic, it's what we're seeing now, where it's there, it's out there, it's calling it. And it's a little bit different because we do have diseases that are out there and cause a lot of illness. So if we have a think about malaria, tuberculosis, HIV, these cause illness across the globe. And don't meet the definition so much of a pandemic in that there's other things that spread other than humans. So whilst with the caveat of TB, so malaria, HIV, they're not as transmissible, and that's where we come to this transmissible thing. So how easy is it to catch? Tuberculosis is pretty easy to catch, but we've got some good treatments for it. We've got a vaccination, not so great. The vaccination, need to do more work on that, but we do have treatments. But what we have found that's mutated, we have extensively drug resistance, Mycobacterium tuberculosis now, where we have people that we can't treat, and that's the risk. Is if that strain gets out, we might have an issue with TB. HIV spread around the world. We have treatments now. People live with HIV. They don't progress to AIDS and die. So the issues there are different now. Malaria causes a lot of grief around the world, causes untold illness and death around the world, spread by mosquitoes. So it doesn't jump on a plane and travel around and infect people. For malaria, the one to worry about there is climate change and what that does for the vector.
They'd all be regarded, presumably, as fairly virulent. So if they were let go, they would take off. I mean, the case of malaria with mosquitoes is obviously not so. Yeah. But TB and, of course, influenza with a bad mutation, such as the so-called Spanish flu in the 1990.
Yeah. So with COVID-19, what we saw is we had what we call the alpha variant. Started off, wasn't particularly virulent. We were still looking at is it droplet spread? Is it contact spread? And these are all sort of fairly academic terms. When it push comes to shove, it turns out that it was probably more along the aerosol. So it floats around in the air. It can be spread airborne, and that's clear now that is correct. And I think this is one of the issues that we've had with the pandemic is that I think a lot of society expects science to be black and white, and if we say it's something, then it shall always stay that way, and that's not what science is. Doesn't mean that science was wrong. We've just developed a different understanding, and when you're dealing with something that mutates and changes, you have to mutate and change your thinking and your science along with that. Otherwise, you're stuck doing something that doesn't work for something that's moved.
I was at a conference a few years ago in Salzburg in Austria, where for the first time in European history, apparently, doctors in human medicine and veterinary scientists were brought together for the first time to talk about these types of diseases. The technical name, of course, being zoonoses, which are diseases of humans that have natural reservoirs in wild animals, so-called, or in other animals other than humans. And at one stage, there was a graphic shown of a virus, the influenza virus actually, mutating as a graphic. And it was like every microsecond something happened. Is this happening with
yes,
COVID?
Yes, clearly this is happening with COVID. And it happens with pretty much every organism. We change as we go along. That's why we as humans don't all look and do the same thing. And that's not because of a particular choice. It's just the way things work. So we start off with the COVID-19 alpha variant. We now, in Australia, the Delta variant is the one that's causing us problems. We've got the Lambda, we've got Mu, I think it's Mu. My Greek alphabet's not great. Mu is the one that's just been made a variant of concern that we're keeping an eye on as well. But this is going to happen. As it happens with everything. And if you have a think about influenza, for instance, one of the reasons that it's recommended that everyone has an influenza vaccination every year is because the formulation of that vaccination changes every year based on the circulating strain. And so for us here in the Southern Hemisphere, we look at the influenza season in the Northern Hemisphere, which happens during our summer, and we go, what's circulating up there? And the team at the Influenza Coordinating Centre down at Melbourne and the World Health Organisation, they go, oh, well, this is what we expect to happen in the Southern Hemisphere. This is what you should put in the formulation for your influenza vaccination, and we all get vaccinated. Sometimes we miss, and the circulating strain decides to be something different, or not decides, but it is something different, and that's how it works. And what we're seeing in COVID at the moment is exactly that. When you have a lot of people infected, you've got a lot of virus out there. When you've got a lot of virus out there, the pressures to change are there, and they happen more frequently. We know this for bacteria, for instance. Your listeners may have heard of antimicrobial resistance, and we talk about superbugs. So in hospitals, we talk about MRSA, multi-resistant Staphylococcus aureus, which is, we used to treat with simple penicillins, and now we have some much bigger and more, nastier antibiotics that we treat it with because it's become resistant to those because of the pressures we put on its development.
And of course, viruses are fundamentally different from bacteria, aren't they? In a number of ways. I mean, first of all, they're not living organisms, really. No. They're just strips of genetic material. But also, of course, their rate of reproduction is vast compared to bacteria, where they will enter a cell and replicate to unbelievably high numbers, rupture the cell, and then off they go someplace else. One of the things that I think disappointing about science in terms of the way we scientists communicate is the notion that we endow other organisms such as bacteria and so on, and even viruses, with intelligence, that they know what they're doing. And so you have things like, the battle against viruses and human beings as if the virus knew what it was doing. But of course that's not so, is it?
No, it's not. And it's a trap that we fall into, and I've done it a couple of times today. But I think that's one of the things about science communication is that what is the underlying understanding of science in the community that you're trying to get your message across to. Right. And I think that science communication, I don't think we've got it right. And I think this is where one of the things that we as scientists actually have to work on is how do we communicate what are essentially some fairly tricky scientific ideas, and let's face it, virology, immunology and epidemiology are not easy.
No.
Even
the words.
Even the words, So they're not easy, and for us to understand, most of us have spent considerable amount of time studying very, very specific aspects, not say epidemiology, but just a specific aspect of epidemiology even, to be able to then communicate that to a broad community, say the Australian public or the global public, with no underlying understanding is very problematic. And then on top of that, when you're talking about a pandemic like this, is the political side of it. Is how do we get that message across in a politically appropriate and acceptable way, because there's other drivers there as well, and so we just have to be a little bit careful on how we say things. But you're right, the virus doesn't know what it's doing. The virus does what it does.
Let's explore a little bit more this connection, I guess, between science, government, business and human beings. I mean, I take your point very well about the notion that we hesitate to use the word pandemic because it does then mean that we bring in all these other things to bear, whereas when it's just simply an epidemic or is endemic in a population, then it's really just the concern of public health. But now it's much more than all of that, isn't it?
It is to some extent. I think if we take it back a little bit, at the introduction you were talking about zoonosis and medical doctors coming together with veterinary doctors. So, we have this concept now of One Health. It is something that we really should be working towards. And I remember, I'm thinking probably 20 years ago, when I was actually working clinically as a remote area nurse, there was idea of health in all decision making. So there was a push. I was working in South Australia, and there was this push that whichever governmental department people were working in, whether it was education, infrastructure, finance, whatever, you had to think about how health was brought into it and how education was brought into it, because you didn't want to be making a decision somewhere over in finance that impacted on outputs in health, because everything is interconnected. And I think that's what we're seeing here, is where whatever decision you make is going to have an impact somewhere, and it's the priorities that you have to get right. So is the priority the budget? Is the fiscal outlook for individuals, for companies, for states, for the country more important than health? And I don't think you can actually separate it that easily. And I think what we're seeing in the public discourse is, you've got on one side, there's people, it's almost made dichotomous, that you're either for lockdowns or you're for business, and you can't be for the other. And it doesn't work like that. And this is where we come back to that communication. On one side, you've got people saying we've got to open up the economy, you have to have business surviving, people can't live without that, and there's some truth to that. On the other side, you've got people, we've got to lock down, we can't let the virus spread, because that will hurt people. And there's truth to that too. The problem is that that's what's played out.
Yes.
Is that you're either for or against one of those two,
Yes.
and you can't be going, actually, we actually have to work our way to it. And I think what we're seeing now is there is some change in the discourse to living with COVID, and I think we're at a point where we can see that we aren't going to eradicate at this point in time. We might down in the future, but I think we've got to we have to make a decision now where we're going. The problem is, if we open up things, we already can see that our health system is stretched. And this is not particularly, it's not necessarily because of COVID-19 that the health system is stretched. We have been in a pandemic for 18 months, and health workers and health systems are tired and that. But prior to that, what decisions have we as a society made to set up our health systems to have some capacity to manage these sort of situations?
Yeah, right.
And I think what we have seen globally and certainly in Australia is a move away from, I guess, the public health side of education and health. What's good for the individual is good for society. And I think if we have a good public health system, and that's not just the public health that people now think about as terms of hand washing and viruses, it's public health in our hospitals, our GP practices and those sort of things. If we have some capacity in those and some, the ability to take on extra cases, then we'll do better. People will be healthier people, good for the economy. People who are sick aren't able to contribute at that particular time, and we have to think of their mental, their physical and emotional health and the people around them. We're too dichotomized into people and money.
So we come in then into all sorts of sensitive areas, don't we, in terms of mandating things. I read some extraordinary data yesterday which said that in countries with a loose culture of adherence to sort of social norms, like Canada and the US and most of Europe, where people dislike being told what they should do, versus tight cultures such as Singapore, China and Korea, there is a 5 times difference in terms of the, if you will, the seriousness of the disease in these loose cultures compared to the tight cultures, with Australia being a noticeable exception. And I read some other figures yesterday that said here in Australia, as you know, with a population of 26 odd million people, we have only 55,000 cases, with almost half of them still active. We have had only 1,000 deaths. Compare that with Canada. Canada, with only 37 million people, less than double ours, has 1.5 million cases. What have we done right?
So right, I think, is a loaded word. What have we done differently?
Better.
Because I think
Better,
different. What we've done differently,
Right.
Is, and I think I take it. I think this idea of a loose and tight society is an interesting one, because I think you'd find that there are people who would suggest that having a government that is more punitive, which is essentially what
tight societies are.
it is not an indicator of what the people living in those communities would like. So
True.
I think that
There's not a lot of choice.
there's not a lot of choice there. That's the thing, and that's the thing. So whether people want to be there or not is a moot point potentially for this discussion. But I think here in Australia we actually have the good fortune to be an island and separated a lot from what's gone on in the Northern Hemisphere.
Right.
And so, when we did close the borders and brought in lockdowns early, I think it was early in February, I think it was last year. That's what set us up for where we are now. Of course, the problem with that now is that at some stage we actually need to let people back in and out of the country. We can't. I think we're past that point, and I think what we have done is we've potentially not taken advantage of that ability to say, actually, we're going to keep this out and to set ourselves up for letting people back in. I think our reliance on say hotel quarantine, for instance, I think it was good at the start. It's gone on for too long. We should have been looking at home quarantine and other measures. The Darwin style Howard Springs quarantine system much earlier. I think now we're too late for that. We should have been able to bring back, particularly Australian citizens into the country much earlier than this. The state and the Commonwealth and state and territory divide is pretty clear at the moment. We've got issues going on around the country between internal borders. That's problematic. I think it is really important that we protect health. And I think, we can see in New South Wales the impact that's having on health services at the moment, with what globally is a very small number of infections. But it is actually having a large effect on our health system. And, I expect that New South Wales is not going to get better in that response anytime soon. I think their health system is going to struggle for the next few months, if not become overwhelmed. Touch wood, we hope that doesn't happen. But to have that happen on a national level would be, fairly daunting for a lot of people. And people are going to die because of that. But we do need to open up. We need to have people. We need to be able to get people back. And I think where we are now is a testament to what we started with, but we haven't set ourselves up for that next step. And I think we're going to rush into it.
How do you feel, as someone on the front line, as it were, in public health, related to people who refuse to accept the notion of masks and social distancing and, worse, vaccination?
Look, my feelings are very clear. These things work, and it's clear that they work. Now, the issue is that they're not 100%, and I think that's where the sticking point is. People are wanting it to be 100% safe, 100% effective, and we're not going to do that. Nothing in medicine or health is 100% effective for everybody. It's just not how it works. I think the idea that the vaccines are untested and potentially dangerous. Well, these COVID vaccines have had much more testing and scrutiny than the majority of the medications that we have available to us for all sorts of things, not just vaccinations. Does that mean that they don't cause harm? Well, no. There are going to be people who will have some effects from having a vaccine. We know that. But we do that with other medications that we use now. If we waited for any medication to be 100% safe for everybody, we wouldn't have any.
I think we're going back to this idea of science communication. Yeah. One of the things that two things, I guess, that we fail to do as scientists is to stress the point that science is really about explanation, isn't it? And it's a tentative explanation based by the evidence that we've got. And if the evidence changes, as it inevitably will, then our explanation itself has to change. So you're right, we can't be absolutely determined about anything at all.
No, and there's also this idea that I think one of the things that strikes me, and I'm not an anthropologist or someone who studies human behaviour, so take this with a grain of salt, is that a lot of the anti-mask, anti-lockdown it's about me. It's impacting me, where we need to actually be thinking about others.
Right.
And I think this is one of the issues that I've seen over the 18 months is that we've moved away from being a society that thinks about us as a society.
Right.
It's more about what's in it for me and what's the impact going to be for me. The lockdowns and the vaccinations, it's not that it's going to benefit everybody. If we didn't have vaccinations and lockdown, not everyone is going to get unwell from COVID. It's not going to be 100% everyone gets sick, but there are going to be people who get sick and die, and if we can limit that, it's better for society. And that's what this is about. It's about protecting each other.
I mean, that raises two issues that we don't have time to talk about today, but I would love to have you back again, because we've opened up all sorts of questions. The issues to do with ethics, in which I know you have an interest, and so choices between this or that in the end are grounded in ethical decisions.
Yeah, that's right.
And the second issue is the issue of precautionary principles, which is something that science does not talk anywhere near enough about.
No, and I think that the precautionary principle is one, particularly for healthcare workers, and my specialty in infection prevention and control. We really missed the boat on that precautionary principle early on in the pandemic, and as a profession should have moved quicker.
So in essence, that simply says it pays to be cautious. Matthew, it's been a delight having you here. Thank you so much. As I've just suggested, you've opened up a whole lot of areas of inquiry that I'm sure that our listeners will want to pursue in the future. So I hopefully we'll be able to get you back again at some time soon. Thanks so much.
Thank you very much.
And thank you all for listening, and I look forward to the next episode. Goodbye.